Hello and welcome to Foot Forward Wednesday webinar for the lovely month of May. My name is Georgina Frank. I'm the project officer and I run the Wednesday webinars. And before I introduce our wonderful guest, I would like to acknowledge the traditional owners of the land upon which we stand and recognise the strength and resilience and capacity of the Aboriginal people on this land. Today, as I am most Wednesdays now, I'm on the land of the Gadigal, Wangal and Bedigal clans, which are part of the 29 clan groups of the Sydney metropolitan area, and they're referred to collectively as the Eora Nation. I'd like to acknowledge all the traditional owners of the land, but also pay respect to elders past and present with us today. Now, I'm going to say our best thing for this webinar is to use Chrome, and if you've got any questions, just pop them in the chat box and I'll ask them at the end of the, and I'll ask our wonderful presenter, Sally, at the end of the presentation. And now this leads me beautifully into introducing the lovely, or I should say, Sally Bond. She's a senior podiatrist at the High Risk Foot Service in the Royal Darwin Hospital, where she has a special interest in improving foot health outcomes for people in ENT, particularly Aboriginal people. She spent over 20 years working as a clinical podiatrist and working over 10 years working in remote Kimberley and ENT. In 2014, she worked for the Fijian Ministry of Health as the project officer responsible for primary foot health training, and she has a Master of Public Health from Flinders and is a member of the SAHMRI-led Top-End Diabetes Foot Complications Expert Advisory Committee. So without further ado, I'd like to hand over to Sally and say thank you very much for joining us.
Thank you, Georgina, and thanks for inviting me to speak today. So I'm also would like to acknowledge that this meeting is being held on the traditional lands, in my case of the Larrakia people, and pay my respect to elders past, present and emerging. Today I'm going to talk a little bit about diabetes foot disease in the Northern Territory context. Some of the topics we'll be covering will be the demographics and background, a little bit about our service up here in Darwin, some of the unique challenges that we face in the top end, and I'm going to conclude with a couple of case studies showing the complexities of the patients that we manage and some of the challenges we face up here. So the Northern Territory is the third largest geographical area in federal division in Australia, and it has a relatively small population of about 245,000 people. And this is only 1% of the Australian population. We have a large Aboriginal population of about 74,500 people, and they represent 30% of the NT population. And many of these, many Aboriginal people reside in remote or very remote areas. The top end, of which Darwin, Palmerston is the largest city, is contained within, has about 200,000 people. So the top end basically consists of Darwin, the Katherine region, Arnhem Land and Kakadu. And so Top End Health is the hospital in which is the health service in which I work, and Royal Darwin Hospital is the primary tertiary hospital in the Northern Territory, and it has 360 beds. So it has a range of specialist services and provides the main hospital for the top end. There are two other regional hospitals, Katherine District Hospital and Gove District Hospital, and they are the local hospitals, one in East Arnhem Land and one in the Katherine area. Outside these centres, most of the health services are delivered through primary health sites and other clinics based in the regional and remote areas of the NT. These are run by the NT government or Aboriginal controlled health organisations. Many clinics have only got doctors possibly 1 day or 2 days a week. And so looking at the top end map, you can see Darwin is up there on the left at the top, and the top end consists of the areas in green and brown. So sort of just to give an idea of distance, Darwin to Nhulunbuy, which is also known as Gove, is about a 12-hour drive. So it's a very vast geographical area with a very sparse population. So you can imagine the challenges of health service delivery. So when we're talking about Aboriginal and Torres Strait Islander health, I'm sure most people are aware that unfortunately there are significant health disparities for Aboriginal people when compared to non-Aboriginal people. Aboriginal people make up to 30% of the Territory's population and yet currently reflect 70% of consumers in the NT health system. So they're definitely overrepresented at all levels of the health system. The geographical distance and remoteness presents particular challenges around the delivery of integrated and consumer-centred care that is accessible, effective, culturally safe and responsive. And we know that Aboriginal people continue to experience some of the poorest health outcomes in the country. And unfortunately, the Northern Territory is no exception. And some of our health statistics are really quite shocking. So the NT has the highest rate of diabetes in Australia of approximately 8 to 10% of the adult population. And this rate increases in the top end for Aboriginal and Torres Strait Islander people over 18 to about 27%. So nearly one in three adult Aboriginal people has diabetes. Our end-stage renal dialysis rates are a shocking 26 times that of non-Aboriginal people. And unfortunately, Aboriginal people are up to 38 times more likely than non-Aboriginal and Torres Strait Islander people to have a diabetes-related lower limb amputation. So I'll be talking more about these foot complications throughout the rest of this talk. So you can see that the risk factors for diabetes-related foot disease are very high. So these are statistics from 2012-13, but it does show that if you look at the graph on the right, the Northern Territory outback is a significant outlier for the number of diabetes-related lower limb amputations per 100,000 people. So we do know we have the highest rates of amputation, and although these statistics are old, or nearly 10 years old, I would say that we still probably are a bit of an outlier in terms of rates of amputation due to many complex reasons. We are trying to tackle these rates of amputation here in the Royal Darwin Hospital High Risk Foot Service. So we are the only multidisciplinary high risk foot service in the Northern Territory. And our role is basically as a team and as a service to consult and manage patients with diabetes or other neuropathic conditions who have an active foot complication, whether they're admitted to hospital or not. And we aim to offer a best practice model of care for patients presenting with ulceration, with or without infection, ischemia, gangrene, suspected or confirmed osteomyelitis, or suspected or confirmed Charcot-Marie-Arthropathy. So our referral criteria would probably be very similar to any other high-risk foot service around the country. We're not limited to people with diabetes. We will see other neuropathic-related conditions, such as alcohol-related neuropathy. And basically, we'll see people as outpatients in our specialist foot clinic or those who are admitted to hospital. Generally, people those in hospital generally have a level of ischemia or a moderate to severe systemic infection. So our high-risk foot service core team, we are a relatively small core team, but we are a very passionate service. Our clinical surgical lead is a vascular consultant, and his role is actually only 0.8 FTE, and that's an NT-wide position. So along with Royal Darwin Hospital, he also goes to other springs. We have 3 podiatrists. Until this year, we only had 2. So getting another podiatrist has been a great bonus for us this year. We have a wound nurse CNC, a 1 FTE, and we also have an endocrinologist and diabetes nurse educator, 0.1 FTE, and an infectious diseases registrar, 0.1 FTE. And as of January 2021 this year, we achieved national accreditation as an interdisciplinary high-risk foot service through the NADC, which was a great achievement. In terms of our clinics, we run 2 interdisciplinary clinics a week. On a Tuesday, we run an inpatient foot round where the patients are referred by home teams or the wards or the emergency department. And this is a consultative ward round where we review all complex high-risk foot patients in the Royal Darwin Hospital. The numbers of patients will vary per week. 6 would be probably the minimum, and we have had as many as 22 to 25, which is nearly a whole ward if you think about the number of patients in hospital with DFD. So obviously that's quite a burden of disease for our hospital. And this tends to happen more sort of in the wet season when I think infection rates are possibly higher. So the team members on that, we obviously have vascular, infectious diseases, the foot nurse, hyperbaric CNC, podiatry, a clinical photographer, and obviously we have access to refer to any other relevant staff and specialties, so P&O, a rehab consultant, ward-based allied health, social worker, etc. as required, Aboriginal liaison officer as well. Our specialist foot clinic is our outpatient clinic on a Thursday morning. So any new referrals, we will try and get into this clinic so they get best practice holistic care from the whole team. It's also for patients recently discharged from hospital for follow-up. So even if patients return to a remote community, we will endeavour to try to get them back to review their wound. Any patient that lives remotely, so sort of outside the Darwin and Palmerston area, is eligible for patient travel, otherwise known as PATS, and they need to come to a specialist clinic. So because this is a specialist run clinic, they're eligible for patient travel. And again, this clinic has clinicians from the following specialties: vascular, podiatry, nursing, endocrinology, and diabetes education. And again, we have access to a P&O, a pedorthotist twice a year, other allied health or specialists as required. We have a documented management plan that is disseminated to referring doctors or clinics. So if someone comes from a remote clinic, we'll send that to the remote clinic. If they're referred from a local GP or a community nurse, we'll refer back to those referring services. And similarly to most high-risk foot services, I guess we're trying to document and comment and plan for all aspects of diabetic foot disease management. So vascular and neurological assessments, a surgical management plan if required, a wound management and dressing plan, and we'll often provide dressings for patients to take back to a remote clinic, wound grading, Wi-Fi and Wagner. We have an IFD, an infectious diseases plan if required, pressure offloading, total contact casts, cam boots, Scotch cast boots. We aim to optimise glycemic control, education, and any other referrals as appropriate. The podiatry service here at Royal Darwin Hospital. So we provide a 5-day-a-week high-risk podiatry service. It's currently based only at Royal Darwin Hospital, although we are starting a service at the Palmerston Hospital next week. Podiatry was only introduced to Royal Darwin Hospital in 2015, and we currently have 2 permanent podiatrists and 1 temporary podiatrist until the end of the year. We hope that we'll be able to roll over that position. The NT, interestingly, considering the burden of disease, currently has the lowest percentage of podiatrists per population in the country. Less than half of that of South Australia, I believe. So, yeah, there's a significant need to invest in podiatry services. Our role here at the RDH, so we manage post-amputation wounds, so transmetatarsal and digital amputations. We do all the casting, so we do not have techs, so we do all the total contact casting, the Scotch cast boots, complex debridement and dressings, including vac dressings. We offer a service, basically a telehealth service where people can call in and ask us for advice. We do vascular assessments, toe pressures and TBIs for inpatients. We have the capacity to offer a prioritised step-down podiatry service for high-risk patients once the wound is healed, but minimal capacity for this. We do nail surgery, and we've recently begun a new outreach service to the Darwin dialysis unit. The governance of our health service, of our high-risk foot service, we have clear pathways and criteria for referrals, a mechanism for triage of urgent cases. We aim to continually promote awareness of the service to external providers. We agree and adhere to best practice guidelines. We have a standardised consultation form. We aim to be patient-centred and culturally safe. And we have a flexible and responsive service. And in that, I mean that we really try not to ever discharge anybody. We like to have a bit of an open door policy here. And you'll often find that someone who may have been a patient a couple of years ago will sometimes just present to our service with a new wound or give us a call with a concern. And that's the kind of service we like to provide here in Darwin. Unfortunately, we don't have a great deal of data. So we know we have huge rates of diabetes related foot disease in the NT. We know amputation rates. However, we don't know ulcer rates, and we really don't know what's going on outside of the major hospitals in terms of admissions, ulceration rates, undiagnosed Charcot. So we have a lack of data because we have no current access to the NADC REDCap database. And due to our very small team, we actually have a limited capacity with the current FTE to collect data. What we do know is over the past year as a team, we've managed over 300 complex foot patients. And this is both inpatients and outpatients, which is quite a high number considering the small population that we have. Notably, we do have a very big burden of disease, of diabetes. We have currently 4 active Charcot cases and probably have managed over 50 known Charcot cases in the past 4 years. So again, this is quite a lot of cases of Charcot in a small population. So some of the challenges that we find, I'm going to touch on some of these briefly. Obviously, the tyranny of distance. So as we know, best practice management is an early referral to a high-risk foot service, our specialist foot clinic. But we need to be mindful that the only one we have is in Darwin. So we have extensive distances for travel. So getting people from a remote community to Darwin for early intervention is not always possible, and there might be a lot of reluctance, quite understandably, from patients who need to leave home to come and see us. We have a very fragmented health system. As you can see, there's a lot of remote clinics, and some of these clinics have a high staff turnover. And referral systems are not always well documented or well known, particularly for new staff. So this presents a challenge for people trying to access help for their patients in remote communities. Who's the right service to call? Within hospital, we have challenges sort of, I guess, with discharging people. So particularly remote patients, foot problems and foot complications often require extended periods of time in Darwin. So obviously long periods of time on antibiotics, people may need to be on a vac. And so they're away from country and family. A lot of patients are away from country and family for a long time, up several months in some cases. And so this can obviously create quite a burden on that patient and quite a desire to get home. And many people do get homesick. We also have a lot of Aboriginal people who, need to go home for cultural requirements and sorry business. And so we try to be very understanding, and obviously people need to go and leave hospital for these cultural requirements and cultural events. There's a lack of secondary services outside Darwin, so we don't have anywhere generally to refer someone for a subacute care. So this often means that they will stay in hospital in Darwin, or we will advise them to stay in hospital longer, because there's just really no adequate services outside of the hospital in which patients can be followed up. And we also have the risk of people leaving hospital, and we don't really know where people are going sometimes, and so we're getting a recurrence or worsening of issues without sort of proper discharge planning, or if people don't have those services in which to attend once they leave hospital. So there's no real clear discharge coordination path. I mean, there are clear paths, but there's no sort of one pathway for people. So we really need to be quite responsive about and flexible in the ongoing care of patients once they leave our care. So this could involve a return to community with a future telehealth or high-risk food service follow-up. It could involve an intra-hospital transfer. It could involve hospital in the home with our ongoing involvement. Ideally, we'd like people to continue under our care as long as they can, and sometimes we do a joint high-risk food service or community nursing management care. So there's a lot of options for people, but not one clear sort of pathway. The other challenges and barriers for patients is that we're a very flexible service, but we are unable to address complex social and psychological needs. We have limited outpatient access to social support services, and our team does not have an Aboriginal liaison officer, a psychologist or a social worker. So we're really missing out on that social and emotional wellbeing component to assist people. And as I've already touched on, there's no community podiatry outside of the hospital currently, and so secondary and post-acute care options are extremely limited. Remote clinics do get podiatry, but it can be anything sort of 6 to 12 weeks, and there's no high-risk food service or podiatry at the Katherine or Gove hospitals. So it does mean that people have to stay in Darwin longer than we would necessarily like them to, and it does mean that people get homesick and want to leave hospital. So what are we doing to try to improve outcomes? We're trying to create better intersectoral collaboration. So this is happening with increased communication as part of the SAMRI-funded top-end high-risk foot implementation working group. So what we're looking is earlier referrals to the high-risk foot service, so promoting the existing pathways or strengthening the existing pathways and trying to disseminate these pathways more effectively. We're looking at increased training of remote clinic staff, so from Aboriginal health workers to nurses to GPs. We're going to try to improve culturally appropriate patient and community education, and I think this is an area which does need quite some investment. We want to increase consumer engagement. We want to improve the secondary care, so increase podiatry FTE throughout the top end. Data collection is obviously an area in which we need much improvement, and we do have the REDCap X proposal in progress at the moment, which is going to be great when we hopefully can get REDCap. And we do have some new podiatry services as part of the high-risk foot service at the Palmerston Hospital and the Darwin Dialysis Unit. So we are trying to target the most at-risk groups of patients initially to improve service delivery and improve outcomes and decrease hospitalisations. I'm going to just finish on a couple of case studies. One is a remote patient, and the second one is a patient from a Darwin-based patient. And both of these patients have had very sort of long-standing complex foot issues. So the first gentleman I'll talk about was a 50-year-old non-Aboriginal male. He was in Darwin for an event and was walking around, I think in thongs, and presented to ED with a hot, painful swollen left foot. And this was probably triggered by the fact that he was normally very insensate, very neuropathic, and he'd probably been walking on this foot for 2 to 3 days before he presented to ED. Basically, as soon as he was referred, we diagnosed Charcot, and he was immediately immobilised in a total contact cast. The complexities of his case, he unfortunately, or fortunately, lived and worked in a regional town which was over 1,000 kilometres away. So there was no podiatry service at all. There was no high-risk foot service at all. So all management, therefore, was in Darwin. He was required to stay in Darwin at least to stabilise this Charcot. And we're always trying to think of ways to sort of get people back home while still trying to prevent a deterioration of the complex foot problem. So we eventually, after a couple of months of him in Darwin, managed to arrange with patient travel to fly him back every couple of weeks for casting. And it's interesting that Charcot is probably not that well known, and I think the complexities of managing a Charcot foot is not very well known outside sort of a high-risk foot service. So getting patient travel to sort of understand this took a bit of work, the need for repeated flights back. Unfortunately, just as this foot was stabilising, 3 months later, he had another acute presentation to the emergency department, and I think this presentation was probably worse than the other one, which was also one of the worst Charcots I've seen. So a very severe acute presentation to ED, and in this case, it was that devastating that he needed an orthopaedic procedure, which we don't really do a lot of up here, which unfortunately got infected. So he had infected KYs as well, and thus was constructed to be non-weight bearing for a period of 3 to 4 months, and basically was in a bivalve cast, treated with antibiotics and very strict non-weight bearing for 3 months. So his overall treatment and management was 6 months in a cart for the left foot, 6 months in a TCC, 6 months in a walker. We got him in an orthopaedic shoe, and although you'll see a picture in the next slide, he did heal, but there's a high potential for ulceration still. His right foot was probably more complex. He was in a bivalve cast and non-weight bearing for 4 months until the wound healed from the infection site. He was in a TCC then for 7 months, a step down to a cam boot, limited mobilisation, and eventually was issued with a second orthopaedic shoe 18 months on. But his life basically changed drastically. So here's the before and after, and yeah, we have managed to maintain an ulcer-free foot since November 2019. But if we think about the impacts on this gentleman, he basically was forced to resign eventually, probably about a year. He was forced to move to Darwin. His lifestyle was dramatically affected, as was his social life. A lot of these things were involved in his sort of work. Financially, he couldn't work, so that was a strain as well. And I know that he struggled with his mental health. He was in an electric wheelchair for a period of time. Now he is doing well, and we have had a great win in that he now has a job and has managed to avoid having to come back to our service for over a year, which is a good outcome for him. But where he is currently living, there is actually still no services for him. So we just have to be mindful that we do have wins, but we also are lacking some of those secondary care services still to monitor these people ongoing. And my second case study is for a lady, an Aboriginal female. She's 55 years old and she lives in Darwin. A history of type 2 diabetes and hypertension. and probably a couple of years ago presented with this foot. So she had an acute neuroischemic wound. So we obviously did vascular imaging, X-ray, MRI, and antibiotics. She was revascularized and managed with standard wound dressings, but unfortunately there was a deterioration after 6 weeks and a diagnosis of osteomyelitis, and this resulted in a right first ray amputation. She had hyperbaric therapy for about 6 weeks and ongoing wound care, and we did heal the wound, 5 months to complete healing, and she was then offloaded in a boot after that, whilst to sort of prevent any trauma to her foot on step down. Unfortunately, a week post step down, she presented with a hot swollen foot, and temperatures on the right foot were elevated, greater than 2 degrees compared to the left. So we had very high suspicions of Charcot. I think we always have high suspicions of Charcot. The X-ray was normal because I think we caught it sort of day 1 or 2. So she was then, unfortunately, after going through the wound healing process, we had to put her back in a cast for another 3 months, 3 months in a walker. And in the end, it was a great outcome in terms of Charcot management because it resulted in no deformity. Unfortunately, after that, 3 months post Charcot resolution, she presented with a plantar wound on that same foot, sort of right second wound, and this quickly deteriorated, and she was diagnosed with osteomyelitis of the 2nd and 3rd MPJs, had a transmetatarsal amputation, further hyperbaric therapy, and this wound also healed after 3 months, stepped down to normal footwear, and she remains healed 1 year on. So although it was sort of a 2-year engagement with our service, and there was a sort of one thing after the other, we did have a positive outcome for her in the end, and she's been sort of able to engage with our service more in a preventative model of care now. So I guess the differences are that she's based in Darwin. She can have monthly follow-up at our foot clinic. She can access our care immediately. And she also had family support and transport. And she's also probably due to the intervention with our service, she's very aware of the risks and will self-refer if required. So I think it's a good demonstration of access to care in terms of where you live, and the value of a high-risk foot service in any hospital. Thank you. I can't hear you. Okay, so thank you for the questions. I'll be honest, footwear remains a challenge for us up here. Getting a lot of people to wear shoes remains a challenge, but when we don't yet have that technology. So it's something that we have got on our agenda, and we will sort of aim to look at that into the future. The shoes provided, so we basically do custom-made shoes for a small percentage of the population, particularly those with Charcot deformity. We do have a pedorthotist come up from Melbourne twice a year, and I'd say maybe over the last 4 or 5 years that I've been here, probably 20, 25 people have received shoes. And the impact of that in keeping people out of hospital is quite astounding. It's definitely helped prevent ongoing issues. Astrid. Thank you, Astrid, for your question. I'll read that. Given the flexibility required in the discharge process and the patient's need to receive primary care, how important do I think is service integration? I think service integration is paramount up here. And I think a lot of the challenges I sort of touched on, one of them is that I think a lot of people aren't aware of the pathway. Also the lack of secondary services, or the lack of high-risk food services, in particular, lack of tertiary services in remote areas. I think the more you're exposed to something, the more you appreciate it and the more you understand the value of it. And I think because at the moment we're Darwin-based, we are quite respected, and those who know about our service and know how we can help people definitely appreciate what we can do. But I think there is a lot of staff turnover and a lot of people possibly, there's a lot of acute presentations that require sort of hospitalisation from the community. And so that middle step is probably missing of where we can possibly prevent acute presentations to hospitals, monthly sort of foot check, which I'm sure is not being done in a lot of places. We do refer to the podiatrist remotely to follow up on patients, but there's also, Aboriginal people can be quite transient and move through our communities, and so sometimes they might miss the podiatrist on that day. So that can also create some challenges. I'm also, yep.
I'm so sorry, Sally.
That's okay.
I can't even see the questions. I'm so sorry, everyone. I'm handing over to Sally, today's moderator, because all the questions have disappeared as well.
Oh, have they? Okay. Rightio. No drama. I think I've touched on some of that. Chris, and we just have to keep moving forward. But there's a lot of issues around resources. And I think now we have a working group that's aware, and it's being driven by the other sectors. It's hopefully going to be more achievable. A liaison officer was vitally important to maintain communication. Yes, absolutely. So thank you, Alan, for that question. So there are, well, when I said it, we don't have an Aboriginal liaison officer in our service, but when someone is on the ward, all of the wards have an ALO. So, and they do have an access to an ALO at the front of the hospital. So we do have that service. It's just not directly related to, so within the hospital, but it's not directly related to our service. So we can refer people to that. Sometimes, as an outpatient service, we do struggle with some of this social and emotional wellbeing stuff.
Is there an active move by, this hospital, or, what can I ask? Is it possible to ask what the limitations are in engaging those services? Because we're looking for our service.
Funding, it hasn't really been.
It's all funding.
Yeah, I think funding. So, yeah, I think there's more awareness around it. So yes, we would find it invaluable. Yes, funding.
Yeah. Yes, funding is always.
It's been identified as a need. Yeah.
So it is a need. And I can ask questions now if it's at all helpful.
Go for it.
It means you don't have to look. One of the people asked, do you have an orthotic department involved in your clinics? Because I don't think you do you?
We do have a P&O department. They're very understaffed at the moment, and we do all the casting. So it's traditionally that the podiatrists, probably the first podiatrist was very good at casting, and then it's just continued on. So soft band. So we put a sock underneath a natural soft band, and I think we probably change our casts more frequently than down south, like weekly. We're changing weekly. We will occasionally, if someone's in one for a long time and really needs to go home, we might fly them back in every 3 to 4 weeks. but it's a weekly change with a good wash of the leg and the foot up afterwards. But it is pretty brutal. We had one guy in a cast for 500 days straight.
Wow, that is really impressive.
So,
yes. How do you stop the tinea? How do you stop the maceration?
I know. It was brutal for him. So
do you ever buy a valve?
Just for that one guy that we did. Yeah. We tend to boot probably more.
But you've got quite a lot of acceptance.
Yes. We do. It's quite interesting actually. And I think often when people have a choice between a boot and a cast and they realise a cast is lighter and they don't have to take it on and off, then we will manage in a cast. It can be quite...
More questions. So I'm going to hand over to you again, Sally, if you can see any other questions.
I think Natalie's asked me about the accreditation, which is wonderful, which was great. And the benefits, Natalie, were that I think it made us consolidate a lot of our policies into actual documents, I think, because, there's always more to do in this space. It helped us identify the gaps in our service, which we've always known is data, basically, and also sort of benchmarking us against other centres. But also it was a great thing to do, to sort of realise that we do have a very good service in a very challenging sort of health environment, and we do have patient-centred care. And yeah, to get that accreditation as the first in the NT we were all pretty chuffed. Yeah. I think that's it.
I think you might be. I've got a lot of background noise, so I probably won't speak for too long. I'm going to say thank you very much for my co-host Sally, who